Assalamu alaikum, sabah al-khair. Thank you for attendance, and thank you, Dr. Amlar, for the invitation, and the SWARs for this prestigious conference. Now, after all of the modalities, like Dr. Amlar said, that we have remaining the advanced cases with the adult case. So, according to the report of 2024 by the American Banking, we have still the same amount of patients who has DULC, although the other modalities of keratoplasty is still increasing. And when we generalize the ectatic as an indication for the keratoplasty, we found out still we have 10 times difference between the patients who has BKB versus the patient who has anterior lamellar keratoplasty. And why DULC? If you have the patient in the early follow-up, we find that if the patient has BKB in one eye and the DULC in the other eye, there is maybe insignificant change in the endothelial cell count. While if we have long follow-up, the patient, and even if has BKB recent than the DULC, the endothelial cell count in the DULC patient is significantly high value for the patient. So BKB has endothelial cell loss more than the DULC patients. That's why we are going for adult patients or trying to make it worse than the BKB patient. If we reviewing the DULC is in a DULC patient has stroma, and we're keeping the host of the endothelium and just replacing the stroma which is defective and putting the button over the donor in the recipient endothelium. In the keratoconus, the stroma is defective already. That's why we need to go for only the DULC, not to need to go more invasive who's going for the BKB. So in patient with DULC, we found out that in the patient with the keratoconus, either ectatic but not scarred stroma, or ectatic with scarred stroma with different presentation for the scarring, which is either anterior stromal, mid stromal, or even full stromal scarring, or heterogenic stromal compromise. Patient has cross-linking before and has severe haze post the surgery, or the patient has already ring before and extruded, or there is any scar having this. Or another patient with prior DULC failure, and we need to replace the DULC due to loss of function, like this patient with a small graft and dehiscence donor recipient, and also there is severe ectasia with high amount of astigmatism. That's why we need to change because of loss of function. Or the patient has frequent stromal rejection. That's why we need to replace because of loss of the clarity. This is the indication of a DULC patient in a keratoconus as according to our clinical practice. So if you want to have a DULC, you need a good plan. If you want to plan, first of all, you have to plan to excise all the pathological stroma by planning for the graft diameter. And the better, according to our researches, that the better graft is the larger graft than the standard graft. 9 or 8.5 graft now is giving anatomical outcomes better than the standard, which is 8 or less, and also outcome regarding the visual acuity of the patient. Another plan, we have to plan for the refined depths. The patient with for DULC, we have to make partial trifine 60 to 80% of the pachymetric map, and to make this we need to make sure about our trifine, which is used to make the partial thickness, knowing that each complete revolution by the trifine makes amount of 250 microns when we make full revolution. So if I have a patient, I have to make pachymetric map for him, knowing where is the trifine will be, and make sure that the amount of trifination I need will be partial, not more than not preventing any complication like this case when we it's found that we have premature rupture of the trifination, and so we have to form the anterior chamber and suturing and starting to our manual DULC just to complete the case as a DULC. And lastly, we have to plan for the safe stromal dissection, and in this stage, anterior segment OCT is the game changer in this stage. So if I have a patient with ectatic, not scarred stroma, I easily go for big bubble direct without anything, making sure that the trifine is good. I have inserting the cannula, making the injection, forming the type 1 bubble, and the keratectomy, following by brief slash, and then excision of the stroma from all till all the trifine, making the bed very clean and regular, and then putting the graft, and lastly I have to suture it. While the case is not different if you have a stroma, scarred, but partial scar, anterior stroma or mid-stromal, but just making sure that at least below this scar there is a definitely clear stroma. So I can go for the same plan. I can go for injection, pneumodissection with big bubble, so I can make sure at least that the big bubble will be formed at this stage. While if the scar is deep and reaching this membrane, the plan should be changed. Because of what? Because of the surprises which may happen after the pneumodissection, the rule, which is the injection can cause the type 2 bubble. Type 2 bubble, if presented, if I'm lucky, I can finish all the dissection. But if I'm not lucky and getting the type 2 50-50%, I can make rupture because the easily bursting of this bubble. So if I have type 2 bubble due to deep scarring from the start, I will go for, this is like type 2, not emphysematous, so I will go manual dissection. If still there is scarring still inside the button, I will go for puncture and just removing the central 6 millimeter just to make the clear visual access for this patient. Also another variant from the deep scarring, when I have injection going for the pneumodissection, this deep scarring cause perforation even reaching the descent membrane, making the air inside the AC. That's why we need to make manual dissection and putting the stromal plug and putting even the graft, then suturing the graft, and then at the end just removing the stromal plug. And this is the post-operative. For deep scarring, so usual deep scarring, I'm not injecting air as to go for pneumodissection or for the bubble. I just going for the air just for visualization, for around the scar, and then going from the start to go for manual dissection just to preserve my descent membrane. And this is the post-operative after removing all the stroma, just putting the graft post-operative case. To maintain the success, we have to make sure about the follow-up is the key. I see the patient first day, first week, 1 month, and so on. So in post-operative, just make sure that everything is fine. I make sure I unburied sutures, the descent membrane attachment, double AC, if it's formed. If I'm seeing just attachment, I just wait for this just to maintain everything, and that by itself it will be spontaneously resolved. Corneal epithelial defect, make sure that there is no, just to prevent any haze. And lately, I have the goal to preserve the integrity of the graft by managing urgent management of the suture related, like cheese wiring, broken sutures, and also for the exposed suture. Infective, because it's a risk factor for infective keratitis, also for the stroma rejection later on, which may cause a lot of rejection, like stroma rejection with failed graft, and later on we go for regraft for the functioning. Regraft, by the way, if reaching the good lamellae, we can just remove the graft before which is implanted before. 1 minute. So in Al-Maghrabi Hospital, we have conducted a 105 eyes of keratoconus has bulk, and the results actually is what is regarding the uncorrected distant visual. There is much improvement from pre-operative till 1 year, and also the slender average reaching around 4 diopters, and the template versus achieved spherical equivalent over time. There is improvement with the spherical equivalent from 1 year till the end and till the removal of the suture. As a conclusion, bulk is ensuring long-term cell preservation, surgical adaptability. Big bubble is a gold standard, but some patients need not go for just for manual bulk. Post-operatively, we have to manage the sutures, safety, where graft can be a good backup surgery. Refractive success, bulk can deliver significant stable improvement in corrected distant visual and astigmatism. Thank you for your attention.
Thank you, dear Dr. Sherif, for this very nice presentation, very nice videos. Now I have a question for you, please. Have you done DALK for a case of high drops? And when can you do DALK after the high drops has resolved? How many time you can wait for the operation to be done?
في الحالات اللي هي فيها early rupture, عندنا high drops, central, no much edema, I can go for DALK. Just to reserve the globe and prevent any scarring and doing manual dissection, just putting the graft and secure the perforation which is already presented in the descent membrane. The patient, if came later on and it's very generalized, we have to make sure that it's totally resolved, and then we go for maybe DULC, but I'm not recommending, because if the area is large, I have to make BKB for this.